topic today is being asked to talk about the science of and importance of taking post-op vitamins. And I have to confess I was a little dismayed at this topic because at med school, right from I think a second year, I spent hours and hours learning about the metabolic pathways of vitamins, and that's just something that I don't tend to keep in my head beyond the exam. And once I've said it, it's all out there. I was sort of wondering, you might want to ask why we insist you take something like this for so many weeks after the surgery when it tastes like this. Or why do we insist on pills so soon after surgery when it looks like it must be the size of this as it goes down. So, I'll stick to the topic. We'll talk about vitamins and why they're so important and why we insist on it. But in order to do that, let me take you right back into history and find out why we think vitamins are so important. If you came back to see me in the 1960s with a weight problem, I would have had the answer back then as well. But it was a jejunal ileal bypass. And for those that aren't familiar with it, what it effectively was, a disconnecting of the small intestine close to the stomach, plumbing it into the end of the small intestine. And that was a very successful weight loss. Substantial weight was lost during that process. Surgeons were very happy with this. Unfortunately, had one problem. Patients died from this operation from malnutrition. So 5% would go into liver failure, 1% go into cirrhosis. So it didn't take surgeons long to recognise this wasn't the ideal operation, and maybe they had to change it. But during that procedure, they found interesting changes that would occur. One was a B12 and vitamin D deficiency, which came on fairly quickly after this sort of malabsorptive bypass. As the operation got replaced by the gastric bypass, which we still have today, and the VBG, or the vertebroplasty, which has been replaced by the band since then, we're still noticing that B12 and vitamin D, for example, is a problem, and that's been described since the 1980s when the bypasses were really beginning to take off over that time. If we look at this cartoon here, we've got the idea that the small bowel is not a uniform structure, and there's different areas of absorption, and this really fits in with this idea of the jejunal ileal bypass and the gastric bypass and other forms of malabsorptive procedures, which can also cause malabsorption of nutrients such as vitamins and other things. You can see there that we've got at the top the calcium's absorbed very proximally in the just past the duodenum. In fact, there's some sort of thought that part of the duodenum itself might be involved in this. You've got the water-soluble vitamins, the vitamin B's, vitamin C's, and the proximal to late jejunum. And it's not until you get to the ileum that the fat-soluble vitamins such as vitamin D are absorbed. So therefore, it gives you the idea that the bowel is not uniform. Bypassing certain portions of it may mean that the other part can't cope. Now, why is this important? Well, length does seem to matter. So when you've got this study here which compares the bypass versus the duodenal switch, and the duodenal switch could be considered as an extreme form of bypass with a much more malabsorptive component, they compared the vitamin deficiencies and found that the duodenal switch at 1 year had reduced vitamin A, reduced vitamin D, and reduced thiamine, despite the fact that these were all given supplementations. So there is something in that the longer your bypass is, the more likely you are to get some nutritional deficiencies. So what is the significance of this? Does this really matter? Well, I think it probably does. If you look at this study, there's three different types of studies that's tried to identify this. The first is a German study, and they just went through a literature review, and they tried to identify all the patients from studies where the studies really describe the complications from weight loss surgery. And they found that 1.3% of patients actually had some form of neurology, whether it's numbness or funny gait, etc. So it's quite a shocking finding. When you look at longitudinal studies from Cherutzi, and I believe that's from Ohio, they looked at 500 of their cases. They had more bypasses than the other one above there, and there was a higher rate of neurology, 3.6%. So that's high. We worry about leaks after bypasses and sleeve, and that's a leak rate of 2%, so it's not common, but something we get very worried about. A rate of 3.6 is very, would be just as much a concern. The Mayo's group 2004 looked back retrospectively back to the 1980s. They had 16% in their series that had neurology. Now, some of that would be better reporting neurology, but they also had a lot of jejunal or bypasses from historical figures there, so 16% is probably still a bit high. So when you think of vitamin malabsorption, vitamin deficiencies and the significance of that, then yeah, I mean, neurology does occur, and we need to be serious about this. When we actually look at what vitamins are involved, there's really 4 that we know about mainly, and I'll really focus on these 4 because there's hundreds of vitamins and we could spend all day talking about them. Vitamin D is the most common, and they reckon 50% of patients will be deficient in vitamin D to some degree post-op. Now, the chance for symptoms with that deficiency is also very high, but it's not neurology, mind. We think it's osteoporosis, so we think that up to 50 to 60% of these patients will have early onset osteoporosis. B12 is also a very common deficiency. A quarter of patients will have some form of deficiency after weight loss surgery, and well over half of those will have some symptom from that. Folate tends to go with B12, and we'll find out why a bit later on, in the same pathways. 20% will have deficiency of that. Not as many chance of symptoms, only up to 10%, but still real. Thiamine I've put in there, not because it's common. Less than 1% of patients will have a thiamine deficiency. It's just that it is so dangerous to be thiamine deficient, and we'll find out why it is. So let's rock and roll and talk about the vitamins individually. Vitamin D was the first one we talked about, the most common one. What is its role? And this is really getting into the science of vitamins. So if I see some glazed looks that I used to have at med school, I'll understand why, and don't feel offended if I pick up on that. Right, so right, bone mineralization is very important. So really, vitamin D can be considered the hormone that controls calcium. That's simply in a nutshell. It controls how much calcium is in the bones, and that's why osteoporosis, for example, is a feature of vitamin D deficiency. You might have noticed, I read that crazy report by some health expert that said sunscreen is harming us because we're now vitamin D deficient. I think I'd rather have vitamin D deficiency than melanoma. But anyway, what it really highlights is that skin is a feature of vitamin D metabolism. There is a precursor in the skin. When you're in the sun, it gets converted, and then it gets to the liver and further conversion occurs. But most of it will be you'll get in your diet. Once it's absorbed into the stream, the liver converts it to 25-hydroxy vitamin D, and that's mildly active, but it's just a stable form. It doesn't get degraded by other enzymes. It then travels in the bloodstream to the kidney, and that's when it gets converted to the really active form, which is the 125-hydroxy vitamin D or cholecalciferol. That's very, very active. That gets to the intestine, helps calcium absorption. Means that whatever you eat, you're going to absorb. Kidney decreases the amount that is lost from the kidney, so it increases its reabsorption. The whole subtitle is it increases the amount of calcium you've got, and also works on the bone for exchange of calcium to make the bones nice and strong. So what happens if we don't have vitamin D in the system? Well, you would have seen this. The first one is rickets, and this is the typical picture you would have seen in the third world of people who don't get a decent enough diet. It tends to occur in children because it occurs deficiency at the growth plates, and the typical bow-leggedness is what you would see with rickets. Now, we obviously don't get that in New Zealand because most of the people are having weight loss surgery in adults, but I think this is a feature when you start considering weight loss in adolescents, which I think someone mentioned and I think there's a bit of concern with the young population coming through. Should we be offering this surgery? And these are some of the things we will have to think about, because if we are all vitamin D deficiency, are we going to get a group with rickets? In adults, tends to be osteomalacia, and osteomalacia is a condition where you get softening of the bones, and the X-ray there just shows where the arrow is. There's a bend in the bones called a pseudo-fracture, and that's an extreme form of vitamin D deficiency. Well recognised, not often seen, but you need to know about that. What we do mostly see is osteoporosis. I think it's still conjectural about what significance vitamin D deficiency and calcium malabsorption does have post-bypass. There is good studies that shows that the bone mineral density is significantly reduced long-term after a bypass. It's also that there is an increased markers of bone turnover, and so it's probably a bigger problem than we realise. However, if you also consider patients who haven't had surgery who are still carrying their weight, they have similar signs of osteoporosis as well. So I don't think we need to get too scared of this at the moment. We just have to recognise that it is important to keep on top of this and watch this space. It will be elucidated soon. Next one we've got is vitamin B12. Vitamin B12 aids conversion of homocysteine to methionine, also folic acid to tetrahydrofolic acid. Yeah, a few days looks already, yes. By tetrahydrofolic acid, THF, is required to form DNA precursors. Methionine is a sulfur-based amino acid, also involved in the structure of proteins, etc. So B12 is an important vitamin because it's a coenzyme, it's a catalyst basically, and without it there's some very important processes that cannot occur. Now it's got a very interesting way of getting into the system. You obviously eat B12, but once it gets into the system, it's acted on the stomach by pepsin in an acidic environment to cleave it off the food product it's in. It quickly binds to a protein which is released in the saliva called an R protein. So this R protein, B12 complex, survives in that acidic environment of the stomach, gets to the duodenum, where pancreatic enzymes then cleave off the R protein. Now it's sitting there naked and it needs a friend, and it's the intrinsic factor which is released from the stomach, which binds into the duodenum, and that complex is now stable and it runs all the way to the terminal ileum. The intrinsic factor has a receptor at the terminal ileum which binds on the complex, it absorbs the B12, and away we go. 6 years med school. Okay. So what happens when we get a deficiency? Well, the main problem we think is the malabsorption of this. So it makes sense that if we bypass the duodenum, then there is no pancreatic enzymes to break down that R complex that's bound to B12, hence the intrinsic factor can't bind to it, hence B12 will pass through the system without being reabsorbed. Also, there's not much acid produced because the food's not getting to the main acid producing part of the stomach. Hence, the B12 will actually cleave from foodstuffs as well. So, the main thing is that you just don't absorb what you're eating. You get a megaloblastic anemia, and the picture at the top is the classic 6-load precursor of the red cell, which I would never be able to pick it unless you told me, but that's what it looks like. The concerning, however, of the B12 deficiency, rather than just the anemia, is you do get neurological deficits. So you can get some gait disturbances, basically stumble when you walk. Paresthesias, numbness in your hands, pins and needles, those sort of symptoms. More concerning, you can start getting dementia if this is not corrected over time, and more exciting would be psychosis. So if you're looking a little crazy this afternoon, eat some B12. One of the concerns, however, of the B12 beyond this is that it's very insidious. It doesn't occur overnight, and there are cases of at least 9 years after their operations who are presenting with symptoms like this. So I think we just need to be a little bit careful. Just because you're B12, you haven't taken it for a year and your levels are fine, doesn't mean you're going to get away with it forever. So you really do need to focus on this. Talk about folate, which is a vitamin B9, but it's mainly used as folate. It's very important, folate in the system. It acts as an intermediate in the transfer of 1 carbon units. Effectively, it's very important in the purines, DTMP and methionine. Now, if you look at the cartoon here, you'll see it's very closely related to vitamin B12, and that's why we often talk of B12 and folate deficiencies in unison. Its absorption is nowhere near as important, as interesting as the B12. You basically eat it and it's absorbed through the proximal jejunum. I've just taken a picture here of the food bar we'll be enjoying at lunchtime, and you see all the nice fresh fruit and vegetables, which is full of folate. Unfortunately, if you cook this, it will disappear. About 95% of it's destroyed by simple heat, so make sure you eat your fresh fruit and vegetables. What happens if you get a deficiency? Well, like B12, you get a megaloblastic anemia. However, you very rarely when you get the neuropathies or the dementias or the psychosis or the pins and needles. That's more of a B12 problem. One thing is, it's just an anemia. Yeah. And no, I could, but it's boring. Right, supplementation can mask low B12. So if you're taking lots of folate, you may actually be masking B12 because it's working on the same system. So don't just take folate. Okay, thiamine is the one I really want to focus on. Thiamine is dangerous and you need to be aware of it. Now, it is a very important vitamin. It's vitamin B1 is found in all cells and it's pretty much involved in all cellular processes. It has 3 forms. The most common form is the TPP, or thiamine pyrophosphate, and it's a coenzyme in the breakdown of sugars and amino acids. It's also used as a neurotransporter in acetylcholine and GABA, also involved in the myelin formation of nerves. So it's everywhere and it's very important. It's absorbed in the proximal jejunum. Carrier-mediated system means it's actively being transported taught it, it's that important. When you have heaps of B thiamine, it will actually start diffusing by passive. So the body is definitely designed to try and grab as much of this out of the diet as it can. What happens if we get a deficiency? Well, you would have heard about beriberi, and this is what occurs. Two types of beriberi, there's the dry and the wet beriberi, and it's mainly related to peripheral nerves. So the dry beriberi is those patients who haven't eaten much, they've been caloric restricted and inactive, and they get peripheral nerve injuries, they get paralysis of the limbs, and you can see this poor gentleman from Third World showing wasting of his limbs. He's using crutches because he can't walk. If you look closely at the feet, you've got clawing of the feet showing small muscle wastage as part of it. Wet beriberi we don't tend to see in weight loss surgery, but that's where you have lots of carbohydrate intake and activity, but you're just not taking thiamine. And that tends to be in the Asian communities where they're washing their rice, because a lot of thiamine's on the husks of the rice. They're eating only rice, high calories, but no thiamine, and they get wet beriberi. The reason it's called wet beriberi is because they're in heart failure, and they get swelling of the limbs, etc. So that's the peripheral nerves, and that's beriberi, but also they can get Wernicke's, which is a more of a central nervous system problem, and it's the triad: encephalopathy, nystagmus, and ataxia. Encephalopathy basically means you're confused and you're a little crazy. Nystagmus means you've got your eyes flicking from side to side, you get ocular changes, and ataxia means you can't walk with your stomach, you've got gait disturbances. So when you've got all three, you've got Wernicke's, and that's more of an acute thing, that will occur acutely. Korsakoff syndrome tends to occur more prolonged, and it's when you have permanent impairment of recent memory. Basically, you're getting a form of dementia. So they often talk about Wernicke's. Korsakoff is the same thing. Now, the thing about bariatric surgery is patients get dry beriberi and they get Wernicke's, and it can occur very quickly. It can occur within the first 6 weeks. In fact, the study that I just flipped through before was of a young woman, I think she was 2 months after her surgery, she presented with this symptom. Vomiting is often a common symptom. So after bypass, if you've got stenosis of the gastroesophageal anastomosis, you can't keep anything down. A lot of those patients that tend to get thiamine deficiency, they're just not getting anything through for the first 6 weeks, and they're at risk. If you do get neuropathy, the recovery can be prolonged. It can take up to 6 months to overcome that, although the initial replacement does get you back pretty quickly, but prolonged to get completely back to normal. So the damage may be permanent. So for those of you having had a bypass, think, oh my God, what's happened? I'm in trouble. Fear not, because even people who are getting a sleeve gastrectomies are in danger now too. And it's really just coming out this year, showing that you don't get something for nothing, and you can't assume that just because you don't have a malabsorptive component to your operation, you're going to be fine. Here's a 2-year follow-up of 100 patients from Switzerland, if I remember. They did not supply any supplements to these patients. They only gave supplements as they required them on blood tests. Vitamin D deficiency, a quarter of patients with vitamin D deficiency in the first year after a sleeve gastrectomy. Nearly a quarter of B12, and also 19% of folate. If you look at the comparison here, Gurish from Germany compared the sleeves and the bypasses, not a direct comparison, it was just looked back in his database, and he saw, interestingly, vitamin D, nearly a quarter of patients with vitamin D deficiency before the surgery. That increased to 32% of the patients who had a sleeve gastrectomy in the first year, 52% had a bypass. B12, 18 to 58%. So that would make sense. More B12 deficiency in bypass, but definitely a real problem in the sleeve. Folate's pretty much the same when you look at the stats there. Thankfully, no one had thiamine deficiency. So I think you have to assume from this that bypasses do have an increased risk of vitamin deficiencies, but it's not isolated to bypass. The sleeve gastrectomy also as well. So I think we need to look at this quite seriously. It can be dangerous, and it is a real feature. So my conclusions are that the common vitamin deficiencies that we're aware of, and we've studied the most, is definitely vitamin D. That's wildly low in most patients, even before the surgery. So I suspect most of us are walking around with vitamin D deficiency in one form or another. Vitamin B12, obviously, and folate, which go together, and always beware of thiamine deficiency. Malabsorptive procedures are more at risk, but they're not the only ones. So even bands, sleeves, and whatnot, they need to think about these seriously. Supplementation is vital, as a sequelae deficiency can be sudden, it can be permanent, and it's entirely avoidable. All right, thanks.